All right, thank you very much. Thank you, Madam Clerk, Kat. Yeah, good lunch, and everybody got along okay. Feel free, there's still some snacks and chips and cookies, or maybe sandwiches, whatever over there. Please feel free to help yourself. We'll go ahead and get started back, and we'll begin with our community development annual update, planning strategy. Mr. Manager, you good to go? Or do you want?
Yes, sir. No, I'm ready. We're going to continue a lot of conversation with where we left off with water sewer infrastructure and its impact on development, but and simultaneously revisit something similar to agenda item 1 and 2 that we began talking about last year at this work session, which is how do we help encourage and support housing development and general development in Burke County after some period of stagnation. And last year, not only did we talk about water sewer, which we discontinued, but we also talked about the regulatory burden that the development community feels in Burke County, and somewhat unnecessarily and somewhat uniquely. And you all gave direction last year. We know that a code that is overly regulated costs time and costs money, and it diverts good development that otherwise could be here. And so you all gave direction. There's been a substantial amount of work done, as you all know, taking action, doing 2 pretty substantial text amendments, one on development density with when infrastructure available, and then most recently, just last month with the text amendment that we did at the commission meeting. So today we wanted to kind of reframe that, talk a little bit about housing and a little bit about current events, and focus on more recommendations. As you all know, we received a grant 2023 to do a countywide housing assessment. We partnered with a consulting firm from Ohio called Bowen National Research. And it is true to say we have been and currently are still in a period of a housing crisis in Burke County. And that simply means that the escalation of price, housing costs, and the availability of housing inventory are not sufficient to meet current demand. And that has a significant impact on workforce. It has a significant impact on public education, ADM, and both of those impact economic development at a policy level. So just a couple takeaways that we saw from that. This is some MLS data that we saw from 2022 to 2023. The pretty significant increase in both average list price and median sales price. Again, seeing that cost escalation continues to go up. If you take that same data for 23 to 24, it went from 11% to jumping 23% in 1 year for average list price. And so we can take that and kind of continue moving through just as evidence of the challenges for finding new housing in Burke County. These are just more takeaways from that 2023 study where we looked at both rental and single family homes that are for sale, and the median price is continuing to increase, inventory decreasing, and ultimately we were able to kind of calculate what the missing number of units were, and across pricing ranges. Really, that was one of the things that the consultants pointed out that was unique here, maybe to some of the other markets that they studied, was there was no specific price point that dictated the housing shortage. In Burke County, it was everything from HUD, government provided housing, through full-blown market-based lake homes. They were, I mean, we were essentially short everywhere. And the what predicated that was just a lack of development. I think we all know following that 07, 08 timeframe, there was a real lag in new investment. And then so there's kind of this catch-up period, really not only here in Western North Carolina, but across the entire state and the entire country. But we can see that we were a couple thousand units short. And so part of handling that, again, was water sewer, and we have completed or working through completing this AIA study, which we just talked about. We were also able to leverage the study to get a little over $3 million grant from the North Carolina General Assembly. The money is tied to water and wastewater infrastructure. We put it into a separate fund. We're calling the Housing Inducement Fund. And the way that relates to infrastructure is there are places, and those were complemented, the AIA study and the housing study really complemented some of these areas where if available infrastructure was in place, that would help buy down the lot cost and provide a pathway to housing. Actually, before we transition over to the regulatory environment review, which Patrick and Bradley are going to cover for us and talk about where we're going as we continue to kind of streamline and modernize our code, working towards a UDO, which we don't really have right now. We have three, and they'll jump into it. We have three different code systems that all have to be. It takes a little bit of strategy and coordination to navigate our system, and putting it in a UDO will streamline that for developers. But inside in your notebook, in the back of the tab that we're in right now, there is a proposed development agreement. And we've talked about this a couple of times, but I think now, as we continue to try to exercise your strategic plan and provide pathways to housing, I'll give you a little bit of a recap of this property. This is a little over 100 acres adjacent to Drummond High School. And there is a developer that has been proposing a housing development there that is platted for about 140 homes. This has been in process for about 5 years. In 2021, the town of Valdez received a grant for $800,000 to put a sewer lift station in right here. So this is Drummond High School. The topography of this property, obviously the river is back here, is going to require a lift station be installed. Back then, the cost was around $1 million. They received a grant. The project really never saw significant movement. And so last year, as we started working towards some of these housing initiatives and developed this housing inducement fund with dollars that were predicated for water and sewer development, we became engaged with the town about discussions of how to make this property develop. And at that time, the lift station cost had essentially doubled to about $1.8 million. The town has used the first roughly $800,000 grant to begin the project, phase one. Phase two has a gap that we would propose via development agreement, splitting that cost 50-50 with the town, using these state general assembly dollars out of that $3.2 million. Our cost would be about $390,000 to help finish the construction of this lift station. There are performance metrics for the developer. The developer's name is Larry Bragg. He owns a company called National Land Alliance, and he is in a joint venture with Moss Marlowe, who we've worked with. They're part of our local contracting consortium here in the county for the Home Builders Association. They also built Eastburg and Jones Ridge collection sites, so we have a good relationship with those folks. And National Land Alliance, Larry Bragg his firm is what's called a horizontal developer. So they do site civil work. They buy land, and historically they lot that lot off, and someone will come buy a lot and then hire their own independent contractor and build a house for vertical construction. And so we in the town have tried to introduce Moss Marlowe as a vertical builder with National Land Alliance as a horizontal developer, and connect this housing inducement dollars to do this lift station so that there can be housing, not on a lot by lot basis, but houses built in a speculative way at market rate. That does two things. Not only gives us affordable housing, gives us housing capacity, but it also gives us tax base. And that's what's proposed here. 140 lots, average home value about $350,000, is over $40 million in tax base, which is substantial, and also again adds housing capacity to our region. So not asking the board to take any action on this agreement today or anytime in the near future, but just wanted to kind of connect the dots of housing study, AIA study, housing inducement, introducing a developer, horizontal developer and vertical together to try to create this housing energy. All of this sewer obviously would go to Valdez, so it's not impacted in any way by Indian Hills or any capacity restrictions. This would be a utility customer of the town of Valdez, for water and sewer. And really this lift station is all that's needed. So I say all that to say, I think the strategy of linking those together has worked, and at some point we'll continue to, try to connect those dots and hopefully get this project moving. The development agreement is framed in phases. Phase 1 would be the developer's required to build 27 homes within the first 3 years. That's 9 a year. And for every home that's not built, they pay us a 1/27 of this grant back. And all of that is contractually proposed to be contractually bound via deed restriction and the undeveloped part of this plan. So certainly I'm happy to answer any questions that we all may have on this proposed development. But I teed the Patrick and Bradley's discussion about regulatory restrictions and housing inducement and all of that. I thought that was a good way to kind of frame a discussion about how we can help you leverage public policy to not do housing, but to allow the market to develop housing in an effective way.
I've got a question. Brian, do we have a lot of places like this in the county? Like, this is where we can develop houses. This has got all the components that'll make it work easier. Here's our sections that we can develop this ready to rock and roll.
The housing study did identify key areas.
Okay.
And this was one of those areas.
So the Council of Governments about 2 years ago put together a GIS site that will show you every parcel of land in our county and the 4 counties that has all of the infrastructure available to start now.
Okay, thank you, Randy.
Yeah. And it aligns with the work that Patrick Bowen and his team did. But yeah, I mean, there's a tremendous amount of not tremendous, but there's several sites that would be very, very developable. At times they're missing infrastructure, which is what we're trying to help facilitate. So again, just some data points of this proposed agreement at full build out. You're talking, estimated $49 million tax base. The pump station is the key to unlocking the property, and phase 1 will be 27 homes, and anything that's constructed below 27 will be proportionally distributed back to the county at about $14,000 per unit. But, I'll let these guys come up now and talk us through the text side of our development code, and we'll answer questions at the end.
Thank you, Mr. Manager. What's up? I'm Bradley Kirkley. My colleague here, Patrick Dickerson, and I will try to keep this active and flowing here for you guys post lunch. Thank you to our clerk for arranging that. It's always good to have the Warden's chicken provided there too. That's a good thing there for us there. But it's important in coming off of lunch to keep the information and the material that we're going to provide to you here now as other items that you're going to be chewing on, because they are important for how we advance and how we continue to move forward for 2026. These things are important. For what we're looking at here, within this slide here, you've got, once again, one of the things that we try to push for is the community of choice and the factors and the regulations here for code requirements and the community needs and investment is an equal balance. So how do we work that together to maximize our potential? Where can we put homes? Where can we develop? Where can we work the code that we turn in half? It's also important to turn and know, and there's not a slide that will turn and dictate this, but the zoning ordinance and the ordinance that we have, they're all living, breathing documents. They all need updating, they all need revisions, they all need tweaking. We can't rely on the things that we had from 1997 to think that it still works today.
Thank you.
And Patrick and I were going to kind of go back and forth here. So at any given time, Patrick may chime in for some of these things, because some of the things that you're going to see within this are things that Patrick worked directly with GIS, and he'll have a little more insight than I will have there for it. The slide here that you see on the screen here is what we've completed so far. We did a complete zoning overhaul back in 2021. The original ordinance was written in 1997. We did a task force, a committee, and a group. That overhaul happened in 2021. And by and large, the majority of the material that was adopted back in 2021 has worked for the betterment of Burke County. It's in a good place. However, as we'll touch on here in a few slides, and as Brian touched on, you've got multiple entities that kind of work in here within this. You've got multiple ordinances that all have to balance together so that we can allow for development and construction. We did adopt their conditional zoning for other flexible standards in mixed-use developments. We did do a reduction in lot size, which was geared more towards if we can reduce the lot size requirement, that opens the door for more homes in a smaller amount of space. And that's key because if we have a housing shortage, how do we make the best use of the land that we have? At the bottom of the screen there, you'll see some other things where we're looking at heading to. Some of those things are items that will be coming to you for review and consideration here within the coming months. And ultimately, the end goal is the Unified Development Ordinance, which is the branching and the connecting of all of these things into one living, breathing document. We have a couple of slides that are of importance. This one here that goes up on the screen here is of maximum importance because this shows from a year ago the direction and the point that you all as commissioners wanted us to develop and do. So as you can see for the 4 charts that are on this screen here, building permits, new home permits, zoning permits, and plat reviews, all those numbers are up. Key one being the up of 59.76% for new single-family homes. It's a huge jump. Keep in mind here, you can't turn and get this category without this one right here happening, because one of the things that Patrick and other members of staff turn and do, county now, we do all plat reviews as they come in for us for the entire county. So this figure right here shows what's actually of people buying property, dividing land out. By you splitting it, it opens the door for that new home, which leads to the zoning permit and the building permit. All these things intertwine with one another in a happy universe. As speaking on 2026 trends, all those numbers that you just turned and saw, those were highs. We've never touched those before. And for 2026, I would certainly like to come back to you a year from now and say that we topped those numbers, that we exceeded beyond what those are. For 2026 so far, for the first 2 months, those numbers are holding pretty steady. So we're at or equal to what we were in 2025. So we haven't had a drop off. We haven't had a decrease in construction and development, which is saying a lot if you really think back to, we had a period of at least 2+ weeks where really no construction was happening because of the weather issues that we turned ahead within the county, but we didn't drop off. Patrick, do you want to chime in on this?
Yeah, we also worked with Glen Alpine and Palmy Springs to do their zoning. I think that's important to just remind everybody. They have their own zoning ordinances and subdivision ordinances, but we administer those in our office. We recently actually completed an overhaul to the Glen Alpine zoning ordinance. Their zoning ordinance had not been touched since the late 90s as well. So we did got that done. Mr. Glines got that finished before he left us, and we really appreciate his help with that. And as Bradley touched on earlier, we are now reviewing all plats for the entire county. Typically, municipalities would have their zoning, their subdivision administrator would review it, and then they would also have a plat reviewer that would review within their office. But now the plat reviewer responsibility falls on the county office to make sure that all of those standards and those requirements are throughout the whole process.
So how does ETJs fit into that? Who is between the city and the county on those particular?
So if it's in the ETJ, it's still in the actual municipality zoning
Okay.
jurisdiction. Yeah.
Key point here to Patrick's comment here on the Glen Alpine update and ordinance. Glen Alpine itself, what Alan put together and assembled really is to try to mirror as much of Burke County zoning ordinance as humanly possible. They have different terms and different regulations, but for us adopting permits as they come into our office is try to make it uniform, whereby we're not looking at 2 different sets of code.
Uniform, we love uniform.
So as we're working towards our UDO, I just want to point out the 4 ordinances that really regulate all of our work. Our first is the zoning ordinance. This is what controls our zoning, how tall buildings can be, how far those houses can be, setbacks, things like that. Our next one moves over to the watershed protection ordinance. This is our drinking water resources. This is our impermeable surfaces, and we basically have a certain allotment that the state gives us that we're allowed to build for impermeable surfaces. Then we move over to the subdivision ordinance. This is how, when, as Bradley was talking about earlier, when someone buys a piece of land, this tells them what they can do with that piece of land to subdivide it. And this is what our biggest next step is that we're working on. And then we also have the flood damage prevention ordinance. And this one uses the FEMA flood maps to basically tell people how you have to elevate your home if you're inside the floodplain, or if you can't build a structure if you're inside that floodway. So that's basically the area where the river typically would reside. And so we use these 4 ordinances, and as we mentioned earlier, it can be sometimes very complex to make sure they're all working together and to understand them. So we're moving towards hoping to clean that up and make it a lot easier for everybody.
This one here in the bottom left, the subdivision ordinance, this is probably, before the rewrite happened in 2021 for the zoning ordinance, this one's probably the most outdated. And to piggyback off of the material that was just presented to you, this comes into effect for what we have for infrastructure, utilities, how the subdivisions on a large scale get created across the county. To touch on something that Brian mentioned before turning it over to us, you guys recently did the adoption of these 5 items here for text changes and amendments. Those are geared primarily to open the door for things like tiny homes, once again, of an appendix Q that allows for construction standards to meet the residential building code if a person were seeking to turn and do that. We did also a rewrite for solar farms, even though we don't have a lot of those within Burke County. The rewrite of that particular section, should that opportunity ever come knocking, we've now advanced our ordinance to show that. The accessory structure, that was a very common one that came before us in our Board of Adjustment that was geared to keep those cases from coming there and keeping a steady backlog of diet there for that board to have to consider the same stuff month after month after month. For a person who may have a 50-acre piece and just wanted to put a 4,000 square foot building out in the middle of it, that was having to come before our board. So ultimately, nobody would ever see what the person was wanting to do.
So yeah, as we kind of started looking at how we want to start updating our subdivision ordinance, there's 2 main areas that we have identified for areas of improvement. Our first area is road standards. Right now in Burke County, if you're wanting to subdivide more than 6 lots, it has to be built to NCDOT standard and it has to be paved. This is automatically a huge barrier to our local developers. Most of our large scale developments where you're looking at like the Valdez Bluffs development, those are always going to have a paved road, and that return on value for developers is a lot higher because they have a lot more lots. For our local folks, they're typically not really going to be doing more than 15 to 20 lots. And we're trying to understand how we can work a little bit better to provide other options for our developers to keep that kind of, not strangle them, I think is the best way to say that. We want to make sure that we're providing as many options as possible to give them access to those lots. And then also the other part of that is redefining what we want to consider a minor versus major subdivision. Right now, that minor subdivision, which I mentioned earlier, is 6 lots or less. We're thinking of changing that number. We don't know if 6 is it's not enough right now, but we don't want to go too high. But that's part of the discussion that we're having right now. And then also we are, as down here, many developers are choosing just to do 6 lots. And Bradley, if you want to go to the next slide. This is what we're seeing all over Burke County right now. So right here, we have this subdivision that was platted back in the late 90s, somewhere around there. As you can see, there's plenty of lots here. And this is served by a 50 wide right of way right here. But right above this, right now, there's only 6 lots that are being able to be developed because that developer did not want to do a paved road. Because
in fact, to be clear, the previous one did not, there was no subdivision ordinance. That's why the density is more.
Yes, to give you your whereabouts, I don't know if you guys can see this, this is actually on Snowville Church Road.
Yeah.
So state maintained road coming here, Central Drive, certainly as much land as what this one way back in the day was developed out on smaller lots. But this developer, because of the road infrastructure costs associated with it, decided not to do more than 6 lots. So we lose essentially lot, this could be doubled right there if we didn't have that regulation in place of 6 or more. Wait, Patrick, I don't know if you got anything on your head, but.
And so a part of this was when I actually first got brought onto the team, we worked with our GIS folks to go drive around the county, and we actually went to 110 of our private roads. We got out of the car, took pictures, measured conditions, everything to kind of understand what our road network looks like. This little bucket, can we go to the next slide, Brad?
Pretty rough, huh?
Yeah. We have, in Burke County, we have 1,520 roads in Burke County that are privately maintained roads. That's about 440 miles of private roads in Burke County. So basically, we went around we found that a lot of our gravel roads were in actually pretty decent condition. So that kind of gave us a little bit of data to understand that maybe these gravel roads could maintain a little bit more traffic than what we currently have in our subdivision ordinance. Across the 162 rated roads that we did, our average score was a 3.03, which we thought was pretty good. That's across dirt, gravel, and paved roads. And then also we found that most of our asphalt roads were the widest, but gravel roads were about 12 feet wide. Public safety and our fire marshal and emergency services want those roads to be at least 20 feet for their vehicles. So I think an option moving forward is making sure that we have that width for our emergency vehicles to get through, but not really hold you down on that paved road requirement. And so here's a few examples of different situations in the county. This road right here serves 22 lots. As you can see, the condition's not very good. But this over here serves about 30 lots, and it's just a 20-foot paved maintained road. And then over here on the right, this serves 50 lots, and it's a dirt, gravel, asphalt, it's kind of all in between. Each of these kind of were different examples that we saw to try to understand how we can see how many lots are being served and how well those roads hang up or maintain over time. And so this is the actual kind of defining factor that we work with every single day. Right here is the big one. Only one private road that is not eligible for maintenance by NCDOT is allowed for each parcel of land. And then also no more than 6 lots may be served by a private road not constructed to NCDOT standards. So this right here is an automatic stop for a lot of our folks, especially that want to do further subdivision down a private road, which we'll have an example of in just a second. So right here is a great example. This is Robert Clark Lane. As you can see, this little green line up here at the top is this actual road. Here's the condition of the road. We have a paved road at the beginning, then we move over into a gravel road. But as you can see here, we have a 126-acre tract that's stuck. They would not be able to do any further subdivision on this tract. They can only put one home on this tract as our subdivision ordinance currently stands. We think that we need to do some improvements to that. So this is really some of the examples that we see all across Burke County, where we have these large tracts of land, some of them near water and sewer access, but their access is pretty confined. And currently, as our ordinance stands, they would not be able to do any further subdivision. So I think this is a question that we wanted to ask the commissioners to kind of think of and ponder on as we're also taking a look at this is, you know, since NCDOT is very reluctant to take over private roads anymore, should we require NCDOT standards for all of our subdivisions? That's really the biggest question that we're tussling with right now. And then also, what number of lots are we comfortable serving with gravel roads? And I think that's a discussion topic for the community and everyone to talk about as well. And then how do we address those private roadways that are preventing further subdivision as that road has maxed out the number of lots it serves?
Yeah, so once again, key things for you to be considering, because in order to go to the next slide, which is actually should be touching on our UDO information, without an update and a redraft of this, we're spinning our wheels over here. We have to touch and fix situations that, for the slides that you just saw, for having a large scale tract that's basically landlocked. You can do one house. You know, without a rewrite of that subdivision ordinance, we are basically handcuffed, because all we can tell a person is one house, one ADU. That's basically all we can do. So we've got to tackle this situation in 2026, so that it leads into the Unified Development Ordinance. By quick show, I mean, I think we have the capability of kind of taking Q&A for anything with that, but just your immediate thoughts off of any of the information that was just kind of provided to you.
Yeah, I'm all for that kind of stuff, you know, especially infrastructure. Y'all know me on roads and stuff like that. We'll get it started on the roads.
As we move towards the subdivision ordinance and the UDO, for those rewrites, it would be with the task force group, very similar to the one that we turned and provided the information to. They gave us feedback that ultimately would go to the planning board. But what we wanted to make you all aware of is that these items, as they come to you, just have it in the back of your mind. What are we looking at? What are the things that are widespread throughout the county? Because as the manager's touched on multiple times, one of the things people lose sight of is that we have so much area of Burke County, 500 something square miles, that we cover a large amount of space, but a lot of it is protected area. It will never be developed. Won't give the opportunity for construction. it can't have that. So those areas that do have that opportunity and do have that capability, we've got to do what we can to fix our housing issue.
Can you guys share with the board what maybe some surrounding counties that also have a major subdivision ordinance, what they quantify as
So-
major versus minor?
Yeah, it varies drastically across the state. There's a variety of different ways. Some counties look at a minor subdivision as anything that doesn't have a new road. That means anything that's from a state maintained road, you can subdivide as much as you want. Other counties have 10 lots that can be served as a minor subdivision, but road standards vary also across that as well. Certain counties want to have paved roads everywhere, and they also have maybe a better chance of getting DOT to accept that. But traditionally, what we're seeing here in Burke, we're not getting many of those roads taken over. So really, a lot of my research right now has shown that that 6 number is too little, but more than 20 would be too much for a gravel road or something like that. So that's kind of the area that we're playing in, and then also trying to understand how we can bring roads that are coming from those state maintained roads into those back parcels up to compliance without causing too much burden on the folks who already live on those roads. That's the other part of that as well.
Quick question. So I'm thinking about a couple pieces of property that I know that do not have a deeded right of way to them. They are landlocked. How do you develop a 15-acre piece of property that has relatively close access to water and sewer, but doesn't have a road? What's the county's part in that?
Well, it's probably back to an easement. We would have to have access because anything that we review as a subdivision, if you divide out, still got to meet Mr. Bishop's requirement to get a fire truck down there because it's basically starting from scratch. So we would have to work in that capacity. But once again, without proper infrastructure everywhere, a regulation in place to give some flexibility beyond 6, it's not worth an investor's time to come forward to us.
So, and there used to be a practice in the county, and I'm not sure if it still is or not, that when a developer would go in and say put 5 or 6 homes, that there was a provision on the deed that they had said, we will in the future take care of this road.
So now there's
My experience is that never stuck.
Yeah, right.
Right. And that's the issue too, is we want to make sure that that maintenance agreement that's signed on the plat is taken care of.
Agreement.
Yeah. And the other thing too is, I think the county can play a role in creating easements. Like we were talking about those landlocked parcels, I think we can take a role in getting neighbors together, figuring out a way to get access to that parcel. I think that's the best role that we can play, is kind of bringing people together to try and figure out that problem.
What can we do to ensure that maintenance takes place?
It's a private road. That's the only stick with that
Well,
is,
I mean, we can make sure that it's recorded
yeah,
and it's legal.
that's correct.
Most of them, even, I can think of a couple that we've dealt with recently that, there is no homeowners association, property owners association, the road maintenance agreement wasn't recorded, and there's no recourse. So I don't know if it's a direct role, but at least making sure that if someone wanted to enforce it, that they legally could is a pretty critical step, because individual homeowners especially don't know all of that.
Correct.
Just a comment I'll make, you just asked for a gut feeling, I tend to think about the private market kind of controlling as much as possible. So my gut feeling is that if somebody has multiple homes they want to put on a given, road, that it's up to them where they pave it, because if people, don't want to be on a gravel road, then they're not going to sell their homes.
Well, but to that point, going back to that, what they were running into, and I used to own one of these homes. It was on a road that there was a promise by the developer to maintain the road. It never happened. But without that commitment, we would have never been able to borrow the money to buy that house. So there has to be teeth in that somewhere, because I did. I went to the bank and showed them that commitment to maintain the road. That never happened.
I think you gotta stay with it every day. It's a pride thing. I mean, it's like it's all over our county. I know Mark can do all kind of work. Everywhere I go, I'm like, why we got paint on these windows and stuff, and we got all be involved in it. It's gotta be, you gotta do it every day. You gotta run the fence line every day, fix that fence. Put some new concrete on that sidewalk every time, This is stuff you do right then.
Correct me if I'm wrong, the idea of having a cap, meaning that there's a range that it converts to, maybe not full pay, but some higher regulatory restriction on road, with somebody being a responsible party, is for getting a fire truck in, is for getting an ambulance in. If you have 30 people on a road and it's just dirt and you get a 3-foot wash, then we have significant public safety concerns. So the question is, how much residential traffic can a road handle? Dirt versus stone versus, different grade of stone versus full pavement. And that's the balance.
I think just kind of summarizing everything, I think we are in a good place with our previous regulatory, adjustments. I think that showing that with that increase in home permits and plat reviews shows that we're moving in the right direction, to at least unlock a little bit more of that land that provides more options for housing to be built. And also reducing that burden, and addressing the housing crisis through those. And then, as like you mentioned, we're studying options for the subdivision ordinance, and that is something that's gonna be a very complex situation to, figure out how we want to move forward with, and then continuing to move forward with the UDO once we knock down that subdivision and, making it a lot easier and transparent for everybody in the community to understand. Any questions, y'all?
What's the timeline on bringing considerations back to the commission to consider?
I think we're also getting some interest in doing that hobby farm, chicken keeping as well, so we're working on that as well. Fingers crossed, hoping for the end of summer. Thank you.
Thank you.
Thanks, Sean.
All right, thanks, guys. Good work continuing. Brings us to our opioid settlement report. We'll recognize Eddie Samuels for that. Okay.
So I can go ahead and get us started, but I do have some guests today that are gonna co-present with me. And they are representing the providers that you guys have approved funding for their programs this past year. So I'm excited for you all to hear from them and hear about some of the work that they're doing. But I'm gonna start us off by talking about some of the internal operations. So here's our plan that I will try to stick with. We're gonna talk about the current landscape of the settlement funds that we've received and what we're spending money on, and also what our overdose fatalities look like. So the last time I spoke to you all, you asked me about the fatalities for 2025, and I was able to pull this with Danny's help and access to the NC Vital Record System. So we're going to go through some of that, and then we're going to hear updates from the providers, and we're going to close out with some recommendations for fiscal year 26-27. So just to start off with our values, when I was building this presentation for you all, I'm looking at these slides, it brings me a lot of pride that we lead with empathy, and the things that happen in the middle, the teamwork, accountability, and performance, it all adds to growing and growth, and it made me reflect on how we were able to grow the work that we're doing this past year into a team of 8 people that are doing critical work in the community to prevent fatalities, reduce the onset of new use, enhance pathways to recovery, and prevent fatalities. So each one of the things that you will hear about today, it all goes back to these 3 categories of what our priorities are under the focus area of public safety and wellness. So all of the pieces, when I first came back in June of last year, my main priority was to organize and stabilize. So I wanted to look at what we were doing, look at how to make the things that we started more efficient, and move forward in an organized and consistent way so that we could continue to build on it. So here is our dashboard, and you saw a version of this last week at the commissioner's presentation. But this is updated to show the certified overdose deaths. So we had 25 certified overdose fatalities in 2025. However, we still have 28 pending death investigations. And what that means is that any or all of those 28 could return, the toxicology reports to be certified overdoses. It's most likely that it will be less than that. And what that means for us is that we're kind of flat right now from this year to last year. So we have not seen an increase, which is the good news, and I'm expecting it to be somewhat lower. We're not seeing the drastic decrease that we saw the year before that, and part of that has to do with the fatality of the drugs that people are dying from. So as I was reviewing all of the death certificates, I can see the toxicology reports and see what happened to these people that have passed away. And we're seeing a lot of meth and fentanyl mixture, and it's just deadly to people. So we're still seeing that highly fatal and toxic substance coming back on these death certificates. And that's where our partnership with law enforcement and with organizations and with EMS comes in, where we can review these things and talk about what's happening in the community to approach this from all sides of it, so we can continue to see the decline in fatalities. So also here, we are still seeing about 370 EMS calls on average for overdose and 118 kids in foster care. So this was from the state dashboard. And what this means is that the 118 that are reported here, it was the primary reason for removal from the home. So as we heard from Corey also earlier in the week, all of the cases are likely to have some involvement with substance use. So 118 out of approximately 200, that was the primary reason. The other percentage of that, there's likely also some substance use issues going on there as well. Overdose visits for the year, you can see this has drastically reduced. We were consistently in the top 10 for several years in a row for ED overdose rates. And this is going back to that reducing fatalities and reducing the onset of new use and evaluating pathways to recovery, in addition to the harm reduction efforts, pushing out naloxone in the community. So what we're seeing is an awareness of things like exposure to fentanyl and drug testing, working with law enforcement, but also engagement with the BEAR team and the community health vending machine and getting the naloxone out in the community. The downside of that is that when a person is using naloxone, or even if EMS responds, sometimes they're refusing treatment. And so that's some of the reason that those rates have declined for the ED visits, and what makes the BEAR team so critical as a point of engagement for when a person does overdose. So even if they refuse treatment, they're still connected with a peer support specialist that can build a relationship with them and prevent an additional overdose or get them connected to long-term treatment that's not the emergency department. So this part here at the bottom, this is really where we want to prioritize our strategies when we're looking at getting people into treatment. So we've saved lives. We are educating the community. Now we need to get people in treatment. And that's the next phase of this, to break the cycle of substance use and opioid use. I also want to add, when I was reviewing the death certificates, there are still pending death certificates from January of last year. So they're still about a year behind on some of the certifications. So the way that we are approaching this, and this is part of that organization that we have been doing over the last year, is creating the standalone opioid response department that coordinates this advisory committee. And the advisory committee reviews all of the data and helps develop recommendations that we can bring back to you all for approval and for your feedback. So you're the ultimate authority on how this funding gets spent. We are the opioid response department and the opioid advisory committee are supporting that and making recommendations to help you make those decisions in a data-driven way. So this is our total settlement overview. Our total disbursements from 2022 to 2038 are around 25 million. So you can see here that this is very front-loaded, right? So these blue lines are actually what we have received. So we're receiving this over time. And it's front loaded for us to be able to invest in strategies up front, and it tapers down over time. And so this is important to consider as we're funding long-term projects. And you can see the middle charts are the funding by strategy. We currently have 5 strategies in the NCA funded. And you can see the activity over time where from 2022 to 2025, we were putting all of the ingredients together to be able to make this happen. We were doing a lot of collaborative strategic planning. And then, as you can see from this, in 2025, we were able to start cooking, right? Start putting some things into play in the community, funding some strategies.
Dr. Samuels, are we still all in option A? We have,
Are still on. So the current programs, there are 9 active resolutions. There are 8 categories here. I want myself and Brandy Greer, the Deputy Director and Opioid Response Department. So you can see these 8 categories here. The BEAR team, low barrier MAT, SACOT and IOP, naloxone distribution, recovery court, family center treatment recovery, and our community instigator. And so out of those, our county-led strategies are opioid response department. There are a lot of words on this slide, but what I want to explain to you about what Brandy and I do is like headquarters, right? So we're sitting and looking at CAD reports, EMS reports, putting all of the pieces in the different systems together to create a coordinated strategy. So I do a lot of the strategic work. I do the strategic work and the strategic planning. And if you all know Brandy, she is in the community doing education and awareness, talking to people, building relationships, building our peer support network. And so we're really tag teaming this to build the strategy and also build the relationships in the community so that we have a really strong system of care. And we know where the gaps are so that we can make data driven decisions and recommendations to you all. And also, we manage the naloxone distribution. And here's a picture here of our community health vending machine. And we since July, we've given out over 300 naloxone kits through the vending machine alone, and close to 200 hygiene kits and wound care kits. And people are using it. So over the last couple of months, when we first started it in July, we saw we were just going out there once a week and refilling a few things here and there. Over the last month or 2, we have had to restock that whole vending machine completely. So we're not sure if it's weather related or if it's really related to awareness and people know that it's there and know where to go get these things. And we also try to make the items that are in the machine really applicable to what's going on in the community. So if it's back to school time, we can add some school supplies in there or things for parents to be able to use for students. If it's winter, we've been putting hats, toboggans, gloves that are donated. So we're seeing a big increase in the utilization of that vending machine. So this is our BEAR team that was established it was launched in January. We established it in the fall of last year. And we are fully staffed with 4 community paramedics and 4 peer support specialists that operate on a 24/7 schedule. So they can respond to overdose calls, night or day, and follow up on that. We also are integrated with mobile integrated help so that they can also respond to non-emergent 911 calls. So what that looks like is we had a person that the BEAR team was going out. It was a frequent 911 caller. And the BEAR team was coming back and saying, what are we doing with this person? We're just going out there to empty their chamber pot. They couldn't do it themselves. And so we started looking at the different scenarios and history in the CAD reports in ESO to see that this person had a mental health history and a substance use history. And so what had been happening is that a nurse was coming out, like a home health aide, and they were going into his house and saying, this is disgusting. We're not going to be here. We're not going to take care of this person. They're, not compliant with care. but that was due to their mental health issue. So now we have the partners at the table, like APA, Spark, High Country, where we can do complex case staffing and say, hey, we have a person here that is truly falling in the cracks. They have a serious mental health issue going on. They also have a chronic medical health issue going on. And because of these two things, neither one of these types of providers think that they can handle it, but together we can. And so the BEAR team's able to address stuff like that on the surface doesn't look like there's a substance use issue or something like that. But once we get involved with people that are coming in through the system, there are a lot of other root causes going on, social determinant factors that we can help address. So this is funded under option A of the MOA under port. But what that also means is that we can move around in those 12 options to also do other things in the MOA, like naloxone distribution, re-entry work. So since we're 24/7, we can also respond to folks that are coming out of the jail in the middle of the night and support that re-entry. So it really opens up the door for us to be able to respond in a lot of different ways in addition to overdose response. So currently, we are actually up to 22 active cases on the caseload. So this is in addition to the calls that are coming in. And looking at the call reports and the CAD reports, from January 1 to now, there were around 1,200 calls that the BEAR team could have responded to. You know, we don't have the capacity to respond to all of those. But that's a signal that we have the potential to really create some capacity for EMS by letting the BEAR team respond to non-emergent calls, getting in there and working with folks, determining their substance use or mental health needs, and then connecting them to care to prevent those recurring 911 calls that are non-emergent. So since January 1, there have been 39 substance use treatment referrals, and many of those were actually transported by the BEAR team to long-term facilities. 10 mental health referrals, 18 primary care referrals, and as I mentioned before, we're fully 24/7, fully operational. And we were also able to return an EMS vehicle back to fleet this year. So again, adding to our capacity that is also complementary of EMS so that they can respond to those emergent calls. And that our team is well equipped to be able to transport and respond to calls also. Okay, so now we're going to move into the provider-led strategy section. And up first, we have Spark. So do you guys want to meet me up here?
Firing in the house.
Here we go. Good afternoon. We are pleased to give you guys an update on our Family Center Treatment Recovery Program. My name is Carrie Herman. I'm the Senior VP of Strategy and Development with Spark, and I have my colleague Sarah Tillery here with me. She is our local superstar champion here for Family Center Treatment Recovery. She supervises all of the practitioners that are out there day in and day out working with our families. So just a few data points to highlight for you guys today. Back in August, one of our implementation milestones was to get our licensure and readiness assessment completed by the Family Center Treatment Foundation. This is something that they do for all providers who are wanting to deliver family center treatment to make sure that as an agency, that agency has all of the necessary tools and resources and leadership buy-in to deliver an evidence-based model. We actually started out with 90% of those best practice drivers in place, ready to launch our Family Center Treatment Recovery Program, which was really exciting to have so many things ready prior to the start of receiving our referrals. Another one of our milestone achievements was getting our first case. So we got our first referral at the very beginning of October. That was from juvenile justice. And since that point in time, we've had 23 referrals for family center treatment come in from different members within our community. Our training and certification. So all of our staff, whether that is our family center treatment practitioners or our peer support specialists, have to go through checkoffs. This allows ourselves as an agency, as well as the Family Center Treatment Foundation, to know that we are practicing family center treatment recovery to full fidelity.
We know full fidelity equals better treatment, better outcomes, longer standing outcomes in terms of recovery. Our practitioners have a year from the time that they start in this model to achieve all of their checkoffs. So you can see we are well on our way to having all of our staff fully checked off well in advance of that year. Savannah, one of our all-stars here, is well over a third of the way through that checkoff process in just a couple months into her employment tenure. So they are very committed to learning and demonstrating at the highest level the competencies to be able to work with their families. To date, like I said, we've received 23 referrals, and 10 of those families are in active family center treatment recovery at the moment. The difference in between some of those numbers is you'll see some of those families and referrals were sent over to our family center treatment program because of the needs that they were presenting in terms of that primary driver. So they, instead of receiving family center treatment recovery under the opioid dollars, they are getting family center treatment under their Medicaid program. 2 of those cases were referred over to community support team. Again, instead of receiving treatment under these opioid dollars, they were receiving treatment under their Medicaid program. And then we had a couple of siblings that were referred, and we identified that primary family member. They are the identified client, but their whole family is participating in that treatment, thus helping to expand those dollars to serve more residents of Burke County. We broke down our referrals for you. So 48% of the individuals that have been referred to us are covered under the Partners Tailored Plan for their Medicaid health plan. 22% are covered by one of the 5 standard plans that we have. Again, we know we have 10 Medicaid plans here in North Carolina. 5 of those are those standard plans. So those are those individuals that at that point in time, the algorithm has deemed them to be a little bit lower in terms of that acuity. We know that's not always an accurate representation. But they are covered under that standard plan. Important to note, the services like family center treatment and other things like that are not available to that under individuals covered under that Medicaid plan. 30% are either uninsured or underinsured or otherwise covered by a commercial plan, meaning that they have very, very limited access in the traditional space of getting mental health and or substance use treatment. And to date, we have had 0 of our individuals who've been covered under the newly launched Child and Family Specialty Plan that did launch on December 1st. That is our statewide plan for individuals involved in our child welfare system. So that's all of our kiddos where the Department of Social Services has custody. Former foster youth are those receiving adoption assistance. And I apologize if I'm going too fast, but I want to get to Farron because she's got some amazing success stories to tell you guys. To date, 37 individuals, so 37 unique individuals are participating in our family center treatment program. So you guys remember I said we have 10 families participating, but 37 total individuals are getting family center treatment because we are working with everybody in that family system. 60% of the individuals that we are working with have either a current or previous opioid use disorder. So we are really trying to target those individuals with opioid or polysubstance use disorder. This number, guys, I'm real proud of. So far, 67% of the drug screens that we have done have come back clean, which means we know tangibly that the work that our team is doing is showing a positive impact.
Awesome.
And then you probably want to know how much money you've spent. Here you go.
All right.
So we did receive some upfront capacity building dollars back in September. And then you can see that as referrals started to increase, the expenditure did start to increase as well. And we will be sending out that February invoice probably next week or so. But that is kind of where we are. If you guys have questions on any of the data, I'm happy to try my very best to answer that before we get to some of these success stories so you guys can see that true impact. I did such a good job that there's no questions. I love it. All
I
right.
didn't catch up. I was too busy trying to listen so fast.
Darren, why don't you tell us some of the direct impact from some of these families that you guys have the opportunity to work?
Okay, so going back to that first referral we got in October, that happened to be 2 brothers involved with DJJ. They had pending DUIs and they had concerns of THC, nicotine, and alcohol use. And then they had parental history use of opioid use disorder. So we met with that family. Our clinician completed comprehensive clinical assessments on both brothers, and we decided the older brother would be the identified client. myself and the practitioner went out to meet with this family on Halloween. And we were sitting down with this family and both brothers looked at us as nicely, but most straightforward and told us we could put whatever we wanted to on those person-centered plans. They weren't changing nothing. They weren't stopping nothing. They were happy with all of their substance use. They had nothing that they wanted to work on. They were only doing this because DJJ told them they had to. So thankfully, Miss Savannah, the rock star, took that as a challenge. And she met with them and she met with the client, the brother, the entire family, oftentimes having to be creative. She was meeting with them at the job site. They have a family business. She was meeting with them wherever they were at. Starting the beginning of January, both the client and the brother have been testing negative in their weekly drug screens, and they are random. They have begun meeting with her separately and together as a family, have started diving into that trauma work, so much so that just this past Sunday, Miss Savannah got a call from the identified client. He was having some depressive thoughts. He was thinking of returning to use and some thoughts of self-harm. And she spent ample time working with him and working through those coping skills that he's identified to the point where he was confident in himself and did not return to use, and had no self-harm. So we made sure that he was safe physically, mentally, emotionally, and was able to work through and help him remember his own coping skills that he had identified. So that's from Halloween till Sunday. So that's our two kiddos. We have more, but that's my star kids right now. But on the flip side of that, we got a referral on December 30th from DSS with substance use, cocaine and THC, concerns of mental health, parenting, and housing. We completed the intake on January 15th. Both mom and dad got clinical assessments completed. Both the client and the partner have been fully engaged in multiple sessions a week where we're addressing substance use, trauma-informed mental health, and parenting. The client and partner have submitted to weekly drug screens and they have been negative. We have assisted them in securing housing. Both are employed, working full-time, trying to visit their children that are in safety placement. So their DSS case plan has substance use, mental health, parenting, and housing as their identified needs. And we've addressed all of those within a month and a half.
Awesome.
So
Yeah.
those are 2 of the 10 we have rocking right now.
Yeah, good, good. Go in. You'll wave.
Yeah, absolutely. Do you guys have questions for us? Again, I went really quickly through the data. I know that you guys have the data, but I really wanted you guys to hear directly the impact that family centered treatment recovery is having on families. And data is great, but you have to have the story too.
Absolutely. It's awesome.
Thank you.
Providing a lot of hope for people. Yeah, thank y'all.
Okay, up next, we have High Country Community Health. And Dr. Meek is also serving as our Assistant Medical Director, that is specific to our care team. So, thank you, Dr. Meek. Come up. Yes.
Hey, everyone. Thanks for having me here today. Good to be with you.
You might need a handout. Or not, couple.
So we did a lot last year. We saw a lot of people. I'll spare you the details. We are on track to see a lot more. These first 2 slides reflect that. We are on track to see a lot more people last year through all of our programs. I want to jump right into the nitty-gritty of what we do and how we do it in short and some of the results that we're getting. So when you hear this term MAT or MOUD, what is that? What are we talking about? So medication assisted treatment, medication that we use to help people stop craving and not be sick, not have withdrawal, so that they'll come back, and see us and not go out and use. So almost always there's a reflex to think Suboxone, right? That's the first thing that almost everyone thinks about. And that's true. We use that medication a lot. So MOUD, Suboxone, but also methamphetamine. The community we live in, as everyone knows, there's a lot of methamphetamine. A lot. And so we definitely have become more and more involved with treatment of that. Alcohol, cocaine, cannabis, And then oftentimes, all of the above. You know, a lot of folks are doing a lot of different chemicals. So when we say medication assisted treatment, one of the neat things about our organization is of the 7 providers, 3 physicians, 4 nurse practitioners, and we just hired a new hire for last week. All of them are involved in some form or fashion with medication management. I've never been in a practice like that. I've been doctoring for 20-some years. I've never been in a practice where all of my colleagues in the practice are involved with medication management. That's huge. It's a big deal. But not only just the medication itself, but treating the comorbidities. You know, the chicken or the egg. Someone is really hurting because of their mental or emotional well-being or lack thereof. It is so great that they turn to euphoria substances, or they're using euphoria producing substances that cause them to be depressed, that alters their mood, or both. And so we have 2 psychiatric nurse practitioners and just hired a 3rd to help address this, which is very, very helpful. Testing for the comorbidities that occur with substance use disorder, cirrhosis, liver problems, chronic pain, the cutaneous issues, wound care from injection site abscesses, screening for the horrific dental things that go hand in hand with methamphetamine use, and dealing with the aftermath of the sort of the worst case scenario, endocarditis from IV drug use. And then everything else, all the bread and butter of other standard medical practice, blood pressure, cholesterol, diabetes, back pain. We have therapy. We have behavioral health therapists ×3, one of whom is here with me today, Jamie Starr. We have folks in the office where at the time of appointment, they can be seen to help go through and process information in ways, develop coping skills, go above and beyond just taking a medication, just getting a prescription. Tackling social determinants of health. So we have patient resource specialists that help folks try to get back on their feet, try to get housing, try to get transportation, get access to insurance. And thinking outside of the box is probably one of the strongest parts of the care that we are able to offer through High Country is outreach. We have a nurse practitioner, a family nurse practitioner, and a psychiatric nurse practitioner to go out in the community, along with Jamie, oftentimes as a peer support specialist and a medical office assistant. They literally go out to encampments. I have started going out to Burke United Christian Ministry, so going to where the people are, the people that can't make it to our clinic, and that has been a big deal in many ways. In harm reduction, helping people, if they're going, first do no harm, right? That's what we say in becoming medical providers. But second, do less harm. People are going to do bad things, but let's limit the impact of those things that they do on public health. And then lastly, teaming up. And so the more and more I do this, the more and more I find I cannot make as big an impact with a pen pad, a prescription pad and a pen, than doing this, than being involved in my community. I'm getting to know my neighbor and collaborating with our other team members, EMS, the health department, Spark, a caring alternative. So that's really where it really is making these connections and building a net so that we can not let people fall through that net. So ultimately, we're talking about transformation. We're talking about getting people to change. Getting people to change behavior is hard. Most people don't want to change. Change is scary. Another thing is that anytime there's change, you're giving something up. There's loss. There's a lot of emotion packed up in it. It's difficult. And we're asking people to try to do that, or people are coming to us to help them try to do that at their rock bottom state. They're having the worst time that they've ever had. The transformation. And so a metaphor for this, my kid gave me this flyer and this made me think this is a great metaphor. Chrysalis, right? The caterpillar to the butterfly.
And so it's been so long, I've been so far removed from basic biology 101. I was like, oh, right, that's how that works. Caterpillars become butterflies. But there's this thing that's slow on the ground. It's creepy, it's crawly, it's icky, it's sticky. It might bite, might sting. I'm gonna stay away from that thing. And then it turns into this thing that can fly, that is a pure representation of beauty and freedom. But in order for that to happen, there has to be some stability. There has to be a place for that thing to anchor and allow this process to take place. So that's what I want to do. I want to catch more butterflies. I want to build a better butterfly den. And I think we're doing that. You look at the numbers, it says we're doing that. So I know that the numbers that Katie showed, you know, this is going to happen. I've seen this happen a lot, but in total, the national numbers and in North Carolina, especially throughout 2025, the numbers significantly went down in terms of overdose deaths. When there are overdose deaths, you know, there's no secret that the prime culprit is fentanyl, and not only fentanyl, but derivatives of that, sufentanil, carfentanil, all these derivatives that are being manufactured oftentimes abroad, and different agents that are being put in, cutting agents or mixing agents that make it more lethal. Methamphetamine is right in the mix, oftentimes so involved. So let me tell you about this fellow. A month ago, Michael, he's 39. 1 month ago today, he died. He quit breathing. He was dead. EMS was called. He was successfully resuscitated with Narcan. And he got established with the bear team. He got established with peer support. This happened about 9 o'clock at night on a Thursday. I wasn't even in the office. I was at a conference, but community paramedicine Bear called me and said, hey, what can we do? We made contact with the patient and again, had peer support with this person, was supported. And he got in our office and he got established on medication about 12 hours after he stopped breathing, without going to the emergency room, without an ambulance ride. By the way, ambulance ride ain't cheap.
Yeah.
About $1,000 on average. So that's pretty fantastic. I saw him Tuesday and he's been engaged. I saw him last week, but he's been engaged for 3 consecutive weeks. He's coming back to the office. So I'd call that a win.
Yes.
So right next to fentanyl, as we talked about, is methamphetamine. And I love this slide because I think it really helps illustrate what we're dealing with. Like every day people say, man, why can't you just do something for those folks on methamphetamine? It's because it's so novel and how powerful it is. So what the drug does is it floods the neurotransmitters in the brain with dopamine, norepinephrine, epinephrine, serotonin, all of which is yee-haw, we feel good, go, yum, yum. And so, you know, what's better than a good cheeseburger? Sex, nicotine, cocaine, meth. Stronger in how it affects the brain. It's so strong, it's stronger than all of those combined. So that's what we're dealing with. So when people say, well, gosh, why did those people keep relapsing? It's because it's extremely powerful. But sometimes things work out. Kevin, 30-year-old fella that I did see him on Tuesday, but hyper utilizer of services. And what happens with methamphetamine is when you ingest it in high concentrations, it releases so many of these neurotransmitters in such high concentrations that it freaks the brain out and causes hallucinosis. It causes psychosis. People start hearing and seeing things that aren't there. They become delusional. They become frankly psychotic. They lose touch with reality. They lose their judgment. But this fellow was in that space and diagnosed with schizoaffective disorder. He was homeless. Ultimately, he did become hospitalized. And through collaborative efforts with Adult Protective Services and community paramedicine was involved, he became deemed unable to make sound medical decisions for himself. APS got him safe housing and transportation to our clinic. He did become established on long-acting injectable therapy, so long-acting antipsychotics. A shot that a patient will get once a month, so they don't have to take it every day, and increases the chances of them being compliant and coming back and seeing us. So I met him on February the 24th, and he had a completely negative urine drug screen. We resumed his long-acting antipsychotic medication, got him plugged in with our behavioral health therapist, and he came back to see me here just a few days ago. And again, he was able to produce abstinence. That's pretty fantastic. And so what's worse than fentanyl and meth is the two together, which of course we see on a daily basis. And so Jessica is a 21-year-old young lady. What's worse is that she's 31 weeks pregnant. Her boyfriend's beating her up, getting high and beating her up, and she came to our clinic in a bad space. We established care on January the 29th. She was currently using at that time. We got her plugged in. We got her on appropriate therapy, medication-assisted treatment. We got her plugged in with behavioral health. Got her plugged in with an obstetrician, and perhaps most importantly, helped coordinate getting her a safe place to stay. So she came back to see me in follow-up on February the 19th and had a negative drug screen. So 2 lives, not 1. So I'll take that. So if you Google opioid deaths in Burke County, this is what I did. It'll tell you this, and here's the bottom line. Current efforts, the county is actively using funds from national opioid settlement to combat the crisis through prevention, treatment, and recovery programs. The recent decrease in estimated deaths for 2024 suggests these investments may be impacting the trend. So they're using year-old information, but they're looking at what happened through 25. But yeah, I think that kind of tells the story. I'm grateful. I love my job. I really like doing what I do. I like helping people that need help, and excited that I'm supporting. Yeah. Questions? I'll try and answer anything. Okay.
And up next, we have the hearing alternative.
How's everybody doing? I think we've been ready to come since about 11 o'clock today, and we were still late. So there you go. But we're glad to be here. I'm Tegan Brown. I'm the Chief Operations Officer with the Hearing Alternative.
Renee Brackett, I'm the Adult Services Director.
And we are very excited if I can figure out how to use this. So since our application and process through that, we have secured our site. We have received our license for the substance abuse intensive outpatient program and substance abuse comprehensive outpatient treatment. We are at 301 East Meeting Street, right there centralized with our corporate office.
And right next door to High Country.
Yeah. We frequent there, don't we? We come there quite often. We just found out right before this meeting, we have been approved through NC Tracks. For those of you who don't know, this is our whole system with Medicaid that helps us ensure that, we are able to be reimbursed. So hallelujah, we should be ready to rock and roll. We are. Good marketing.
Yeah, I mean, we've been busy. We've not just been sitting there waiting for, this thing to happen. So, one of the things that we've been doing is marketing with, all these folks that you see. And, because of that, We've gotten referrals, we've gotten ourselves established in the community, people know we're there, they're calling us, the word's getting out in the community and people are starting to walk in and ask for the service. It's awesome.
Yeah. I got that.
We've got our staff hired, everybody has been trained in what the fidelity model of the matrix model. All our staff are trained and ready, so we're just waiting on the go-ahead with the Medicaid folks, and we'll start the groups.
Yes. I think for us, that's a big milestone. These positions are very scripted as far as specific licensure, their experience, certifications. And so we are really excited about having our team staffed and ready to go.
And there are certain levels of staff that we have to have. These programs do require what's called an LCAS, that's the licensed clinician addicted. Yeah, anyway, that's the master's degree and you're taking a test, you know what you're doing. They have to be on site 90% of the time when the groups are implemented.
Vacations, that's,
Weekends, holidays, so they have to be there. They're hard to find. In addition, we use the CAD-Cs, that's just a level lower. They also go through a certification process, and we've secured 2 of those. And we have 3 LCAS. One is we're using as a team lead, another one we're using as a program manager. But we have plenty in the house. Of course, can't say enough about what peer support will do for the program. And right now we have 2 of those. We'll have another one in training later this month, and we're awaiting another one to transfer over once we get started. They'll transfer from another program we have at Caring Alternative. And front desk staff.
Yep. All right, backwards again. Oh, sorry. I think you mentioned our training, so we are using the matrix model as our evidence-based practice. All staff have been trained. We have, we were given the initial startup funding of $60,000, so that's helped to support the onboarding of these staff as well as their training. The training is quite expensive.
And we did send one of our LCAS through Train the Trainer, and so that's a little bit cheaper on the side. That any staff that we hire in the future, she will train.
This is very exciting. So this is one of our big milestones. Just through the word of mouth and some of the marketing efforts, we currently have identified, actually more than that, right? 16, I think, 16 IOP ready for those 3 days a week, 3 hours per day of group therapy, intensive outpatient group therapy.
And one of those was the fellow that Dr. Meeks referenced that came in. You got him on Suboxone within 12 or 24 hours, and then we picked him up and wrapped around him, even though we cannot operate him. He will be in this group once.
And just to piggyback off of that a little bit, so since we can't technically operate until all the things and red tape with Medicaid has occurred, we are using our LCAS to do, and our peer support to do that wraparound of outpatient and then community-based service. But we don't want them to fall through the cracks, right? They're coming through the door. We want to get them, into services. And then the other impressive thing is 6. 6 individuals currently meet the criteria for the comprehensive outpatient treatment program. And that is a higher level of care. So the SACOT is 5 days a week, 5 hours a day, minimum of 20 hours of treatment a week. There's already 6.
And these programs cannot go more than 2 days without occurring. So we're prepared that if Easter Friday, we're up and running, we're going to have to be there either Easter Friday or Saturday. And so, holidays will make a difference to this program. And staff know that, and they're very energetic, and they want to give and they want to serve. These programs are very scripted in what must happen.
That's hard to find staff that will commit to that kind of stuff. Okay. Yeah, you guys have questions for us?
I'm just blown away by all the people in our county that care so much for people. I mean, that's really, come on. Thank y'all.
Absolutely.
Well, if we have a lot of people, we make hiring priority in this program. People who have the lived experience, they've been there. Some of the folks we've hired have gone through these programs. And you will hear them oftentimes say when you're doing an interview, I wish this had been here for me, or this is what saved my life and helped me get where I am today. It's that kind of dedication that you have. Thank you.
Jeez.
I want to back up a few slides here and go back to Burke County Treatment Court. So this is an example of how I track data on the back end. So part of the work that I've been doing is standardizing reporting for the programs that are funded. And so each one of the providers has a portal form that they fill out that's submitted to me each month. And then it's turned into a dashboard so we can track where we are on our performance measures. And so this is an example from Burke County Recovery Court, and we can see the total active over time, new intakes, OUD eligibility, and different measures that we wanted to track and look at as we're evaluating the contract. And so Burke County Recovery Court has on average around 20 to 23 active participants each month that are in the program, and it's about 50% males and 50% females. And we are evaluating standardizing recovery court across the prosecutorial district with Caldwell County. So we currently have a contract with the Cognitive Connection that does expire December 31st of this year. And we're looking at changing that to be more of a standard operation as what is happening in Caldwell so that we can align those two districts. And so let me fast forward a little bit to where we are, where we're going now. So we made it through the plan accordingly. What we're looking at is super exciting. I think we achieved the goals of reducing fatalities, enhancing the treatment pathways, like you've heard from these providers that are actively working together, serving some of the same patients, communicating with each other, and building the provider network here. And that's what we wanted to see, and we can actually visibly see it happening right in front of us, which is really cool. A really essential piece to this is going to be the facility-based crisis center. So this, we are in position to start moving forward with this program or this project to build a facility-based crisis center, which is a 16-bed facility. The average length of stay here is 7 to 14 days. And what this does is it stabilizes people in mental health and substance use crisis so that they can get connected to longer-term treatment if that's what they need, or to services in the community. So we envision this having an enhanced intake system. So what that looks like is if we have involuntary commitments, it's the first evaluation site. So that frees up our law enforcement from having to travel around when they have a site that they can go to with their involuntary commitments to be evaluated. What it means is people coming in from the community or have an open door to come in and have an assessment and be connected to peer support or other treatment. What it means is like if family members, I get the most frequent calls that I get from the community are mothers of adult children that call and they're so upset because they cannot figure out how to help their children. They can't figure out, they've tried everything that they know how to do and they're really just lost. And something like this in our community, it is a pathway for us to help them get there and get connected with the BEAR team and our other supports that are here today. So I'm really excited about this and looking forward to seeing this happen. We'll build a team to help get it up and off the ground. We're planning on remodeling this building. It'll need some additional square feet added to it to have rooms and office space. We also would like to see it have some space for groups and other providers to come in and be a part of it. So again, really looking forward to this. And so this model, this diversion model, if you think about what's happening now, people coming out of the jail, a lot of them do have some reentry support through partners or Catawba Valley Healthcare right now that we're also help supporting. But the ones that don't, the ones that fall through the crack, where do they end up? A lot of times in the emergency department, back in jail, through some other justice involvements. Right now in the community, we have this cycle that's happening. And our intervention points are like the emergency departments in jail. That's the solution that we have as far as like crisis stabilization. So this model gives us an intervention here for people that are coming out of jail, before they get into the emergency department, repeat utilizers of EMS. We can help get them into this space where even if they don't need an inpatient stay, they can still get assessed and connected, and it breaks the cycle. And from there, we can connect to long-term treatment. So we did some site visits to TROSA and some other places this year that have that year-long, 2-year-long treatment program. So this is where folks would need to go to become stabilized so that we can get them placed in those other places that have capacity for them. And we have the ability to help transport now with our care team. And so our spending plan for fiscal year 26-27, what we're proposing is continuation funding for the programs that we have started this past year. As you can tell, a lot of the programs, they are fully operational, but they've just got there and they need some extra time and support to be fully impactful. The way that we have the contract set up is like fee for service. So these guys are only sending us invoices for people that they're serving. So we want to continue to support the providers that are here today to see them grow the programs over the next year. And then we want to also add some capacity here to fund another priority. So we've spent a lot of time in the Opioid Advisory Committee talking about specifically recovery housing and prevention, and how do we get there, and how do we set aside funds to be able to fund programs under those priorities. So this is a model for continuation funding with an additional allocation for RFPs for providers to also come in and offer the services that our committee and you guys prioritize. Do you guys have any question about that? And here you can see our available balance. That is prior to our 2026 allocation.
Can you talk just for a moment from a timing and an operational perspective about trying to build this model into the standard budget process, how that feeds into today, so that we don't have start, stop throughout the year. That doesn't mean that additional resolutions and opportunities won't come up during the fiscal year, but we're trying to again standardize the opioid settlement component with the standard budget process so that it's cohesive.
So, and you know, I have felt like I have a pretty good understanding of the budget resolutions and the process to fund things under NCMOA. But even sometimes I'm flipping through the resolutions. When did we fund this? When does it expire? So by lining up things with our county budget process, it really streamlines things for you guys too, where you know exactly what you're funding, when it's funded, when it expires, when we need to review it. And then we have the capacity to evaluate additional things throughout the year that we want to fund because we've built a system in place for continuation funding of things that we have now stabilized that process so we can look at what do we need to do next. And another thing that I think we can do once we get this system in place is start looking at how do we pull in grant funds to support additional programs that way, or to grow the programs that we've started, to really be able to leverage our opioid settlement funds to bring in more funds to support what we're doing. And if we have that process in place, it's good, it's working, it's a well-oiled machine. It gives us the ability to have the capacity to bring in those other funds too.
So are opioid settlement funds allowed to be used as a match?
Mm-hmm. Yeah. Which is pretty cool, right?
Other questions? All right, Katie, thank you all of you providers for being here with us today, giving us reports of where you are.
Yes.
Lots and lots of good work going on here. Again, thank you so much for what you're doing. We'll give you 5 minutes, well, maybe make it 4, 5 minutes, 2, we're gonna start that.
Make it 3.
Just calm down.
Getting all set.
Mr. Chairman.
I think he's gonna be really good. What I'm taking notes, I really don't want to have to watch this. Thank you. Not down, okay. They don't get you stretch. My brain is like, it's like, okay, like that. He could have died, not that great, instead of being a fan or whatever that's called.
We call it. Help provide service to them.
I believe that there's a lot of job association. We don't have. About 8 o'clock, I'll be on the road. So I'm obviously, so it's about Thursday, Friday, I'll be around. It's fine. I'll leave after conversation. I probably was like, sitting there, I mean, sometimes usually when I get in the car, I'm good. If I get tired, I'll stop. I actually know where I can stop and take it by myself. I've done that to drive for 30 years. Well, long enough. But yeah, so, and then I'll be back the following. 18th. I gotta get it. And I'll be.
So I know when you right.
We will.
I made.
We stopped, up in
I had the other day, even though my student, something like that, I like working. But I brought it home, for now, the other day, I just don't, that's the thing doesn't leave as well and stuff, but, shout out to yeah. Yeah, he got that spot, so I think he's was on his way, not on his way. I didn't see that, and I saw it.
Needed to be responded.
Yes, sir. Yeah, sure, I'd be holding this up.
He's heavy on that gap. We can link out to a ceiling.
Nailed that for Manager, capital projects update and forecast.
It's some money.
Thank you. So totally changing gears, but I do hope that there's been some uniformity and consistency through today. Major pillars, that will be, components of the proposed budget for fiscal year 26-27. I know we've bounced around project to project, but all building blocks that, staff need direction on. Want to make sure that we're providing commissioners updates on investments you've made in prior years, but also required investments, that'll be moving forward. A big part of that, we've had a hyperactive, capital improvement program over the last 3 years. That the first ever capital improvement plan, 5-year forecast that was, approved by the Board of Commissioners in Burke County was in 2023. Now we present that to you annually at this work session. A copy of that is in your book that's updated. And really, I want to walk through what is included in that plan, so that you all have really a comprehensive update, as well as the resources that are required to continue the momentum behind that plan. I think it's critical to say the capital improvement plan, I think touches all points of your strategic plan, and it really it complements that, if you will. The amount of resources required to adequately fund capital is pretty significant, right? And we obviously operate in a period of limited resources and high needs, and I think that's why it's so important. Really, when we put this plan together, we're trying to consider, I think, a couple things. One is, where do we need space? Right, space is incredibly expensive, and we've seen significant cost escalation. So an example there would be we're working on rectifying it, but historically, Burke County, like a lot of public institutions, have used very expensive square footage to store records. Right, bankers' boxes of records would fill up a room this size. And that is just incredibly expensive. So what are our true space needs for the operation of the functions that we're trying to operate in? Nothing more, nothing less. We also want to make sure we have good structural assessments of those spaces. That will include, mechanical, plumbing, the condition of the space. And then lastly, how are we going to fund those things? We should have debt management policies, fund balance policies, things that are set by the board that are essentially parameters of how staff should be operating our capital program. I think it's important that now that we've drafted this 5-year plan, that we stay committed to it. We have to have, I think, 3 competing lenses. Number one, it has to be something we can afford, right? Like, it doesn't make sense to put things in a plan that you don't have a path to pay for. You have to stay committed to it. You can't start and stop a capital program. Those things have a way of compounding and really, preventing you from moving forward. And I think you got to ask yourself what's next. And a big part of asking yourself what's next is understanding, those out year components, which is not just what's broken, but it's what's coming next. And part of that means that you can have capital priorities that are simply unfunded, but they're still priorities. They're still emerging issues. They're still needs that you're forecasting. But you should, inside your plan, differentiate between what are critical asset replacement or additions that are funded versus maybe priorities that have yet identified a funding source. Perfect example we talked about this morning is Indian Hills. Critical, gotta be in the plan. We've got to be moving towards how do we get that done. Currently, there's no dedicated funding source for that. Something that's been on your capital plan, and I think Jim may have stepped out, but, space at the library, that's something that's been in the plan now for 3 years, going into 4th year, but still no dedicated funding source. Identified other fund, assets that were in your plan, courthouse, animal services, EMS, the HRC building, all are on the, I guess, the more vertical side of this path. Means we've laid it out. Also critical to your capital improvement plan is making sure that you, set timing. So you're putting resources, funding strategies along with timing, put parameters in place for any type of, financing agreement. So the things that we've identified in your plan, that you annually, when you adopt your capital improvement plan, you're re-adopting these policies, right? So this is how the Board of Commissioners has direct hands-on impact on the financial health of Burke County from a borrowing perspective. So the 3 primary debt analytics that we look at are 10-year payout. So that is what percentage of your debt principal will you pay off in the next 10 years? We all know that most amortization schedules are going to go out 20 years or beyond. So what percentage of that you pay off over a 10-year period shows where you are in that debt curve. How close to the back end of that schedule are you approaching? Our policy, which is a direct recommendation from firms like Moody's and S&P, is that no more than 50% of your debt needs to be paid off outside of 10 years. We far exceed that. Currently, we're at 82 within 3 years. In the absence of issuing more, we would be at 100%. So we're incredibly competitive. Healthy. We also look at debt service, which is the amount of principal and interest we have to pay each year as a percentage of our total expenditures. And we say that, again, these national standards at or below 15%, meaning no more of your available funding sources should be dedicated to debt, no more than 15%. In the FY26 budget, we're about 1.5%. So incredibly healthy there. And then the last one is what is our total amount of debt compared to our assessed value? Our assessed value would be our property tax base, which is our ability to generate revenue. And we want to make sure that we're less than 2.5%. And we are basically 0.25%. So those are the exact same metrics that the local government commission, any type of bank, any type of bond rating agency would look at to assess your debt load capacity, and we're in a great spot. We also have a minimum fund balance policy that's included in your capital improvement plan. Again, each year these can be modified or changed. These are the standards and the recommendations, but every year that we adopt this capital improvement plan, we're also adopting these policies. So dive into it just a little bit. Looking forward for the next 5 years. We've talked about funding and debt position and policies. We also talk about major, non-major. If there's ever truly a fluid plan that changes, a capital improvement plan is that. You certainly set points of emphasis and set goals, but things tend to pop up that you had no way to anticipate, and you've got to be able to have flexibility in the margin, if you will, to fold those in. Inside of your capital improvement plan, revenues are prioritized in this order, and funding sources. Anytime we can seek grants, maybe that's competitive grants through an existing agency, or maybe it's, again, as we talked about with Indian Hills this morning, in direct legislative appropriation. We also, back in 2023, for the first time in the history of Burke County, established a dedicated capital reserve, which our department heads that are in the room are very familiar with, but we have essentially created an escrow, if you will, that's an overfunding of operational capital, anticipating future capital needs, and that you'll see that in your plan, and we'll talk about it in just a moment. It equates to about 1.1 or 1.2 cents on your property tax rate every year that we're trying to fund, and an example of that would be something very simple like replacing the roof at Foothills Higher Education Center. An enormous building, 116,000 square feet, a roof on that building is $1.2 million. And if we don't do a good job of forecasting that, and we show up and all of a sudden we have to put a roof on a building, we've got to come up with a significant amount of one-time capital versus setting, maybe we amortize that over 5 years and put that in this capital reserve, so that it's not as much dynamic pressure on the property tax rate in one given year. We obviously do pay-as-you-go as our next option. We primarily do that for rolling stock and operational capital. So if it's an HVAC unit or something like that. And then lastly, some major projects will require debt issuance. We've seen that in the past with ambulance fleet replacement. And we talked about that with the HRC, the DHHS buildings that we're in the design process for. So that is at times the most appropriate financing strategy. We also, just as a reminder, have a very positive, we're in the top 20% bond rating for counties in North Carolina. And that's largely due to our significantly low debt load. When you look at our current debt load, now this was at the end of last year's audit. We had about $12.6 million on the jail. And we owed about the rest of our debt. That's the only county supported debt. The rest of our debt is about 15.8. It's maintained, although it's certainly the liability is on the county. From an accounting perspective, it's school debt that's paid for with school proceeds, primarily Article 42 sales tax and lottery proceeds. So no local property tax dollars go into any of that school debt. I mentioned your policy that you've adopted. 10-year payout was one of them. You can see here. This year, I think in October of 2026, both Pat and Drone will be paid off. That debt will go away. That's what's going to help creep this 10-year payout percentage up to 100%. And then the rest of it would be the natural amortization of the jail. And then you look at debt service payments, and that means what percentage of our general fund expenditure budget has to go towards debt service. And that's roughly 1.5%. Here's just comparing some of those analytics to, again, state and national medians that Moody's would look at. And in every category we rank as strong as we possibly can. We're not going to be a AAA bond rated county. And the only reasons for that have nothing to do with affordability, payment consistency, or debt load, and has everything to do with socioeconomic indicators that take a tremendous amount of time to change. Household income and educational attainment and average wage and some of those things are what would drive that. So inside of your plan that's proposed this year, we'll start off with rolling stock. We've got about 282 vehicles in our system. We annually evaluate those based on mileage and condition, and we can tell which ones are heavily utilized and maybe utilized less. Next year's budget has an approximate allocation of about $1 million for sheriff's office. He mentioned this morning they drive about 1.5 million miles a year. Those vehicles tend to get driven fairly hard. And so we've also got a little over $240,000 allocated for additional rolling stock. Now, one of the big areas that we need to talk about this year and begin planning for is ambulance fleet replacement. The county operates, we have a fleet of 18, I should say 18 ambulances. And in my mind, I categorize them as 11 old and 7 new. The 7 new were bought in 2023. 5 is a component of a capital lease, and 2 were bought independently. And those ambulances are, over $300,000, depending exactly which models you get, but certainly a very high cost, but critical asset. And what I would say is typically as a matter of management and strategy, they have such a low depreciable salvage value that ownership is irrelevant. The only reason owning an ambulance may be a good idea at times is because the box that sits on the back of the drivetrain. So if you take the ambulance box off, you can put that on a new chassis, right? You can buy to reduce the cost of fleet replacement. You can buy just a truck, and then take the box off an old one and put it on a new one. That is the advantage of owning. The disadvantage of owning is we can buy a police cruiser for $50,000, drive it for 5 years, and the salvage value, what we can sell it for, maybe $7,000 or $8,000. The decline in the depreciation is not nearly as significant as buying a $350,000 ambulance, driving it for 5 years, and it's worth $5,000. There is no secondary market. Public safety institutions don't want to beat up ambulance, and nobody else has a real purpose. right? I've seen some plumbers in them, but there's not a significant secondary market. So that I think advocates at times in favor of leasing, where you adopt this annual payment that's built into a lease service payment. At the end of 5 years, it's like a copier, right? You give it back to Sharp and you get new copiers with new technology, and you don't lose all of that embedded financing cost. I think both are depending on your situation, the timing, the cost, both have advantages. And you got to kind of fit it to your team. So that's just something to keep in mind as we work through the next couple of slides. I think it's important to say we run 8 911 crews. These are on 24/72 shifts. That means you work a 24-hour shift at a base, and you're running calls, and then you're off for 3 consecutive days. We also run what we call peak shaving truck. So looking at call volume, usually 10 a.m. to 10 p.m., you're staffing a truck right at that point to help alleviate some of the call volume. And then in a facility, this would be a unit that pretty much moves people from the Valdez emergency room to Morganton, or at times discharge patients who have to go back to long-term care facility, nursing homes, sometimes to a higher level of care, Charlotte Baptist, those type of things. And this is, as I said earlier, a breakdown of our fleet, which has right now an average mileage of about 143,000. We have what I call 11 old and 7 new. We got 7 trucks that are in good spot. They were all bought in 2023. We need to start talking about moving them to the old section and getting the new, so we don't end up in a situation where we're shutting down trucks and not being fully active because of mechanical failures, which is where we were in 2023 when I arrived. Here's just a little bit more detail about our fleet. You can see these 11 old, 193,000 miles on average. Now, even though this is fascinating, even though we only drive them 15,000 miles per year, the cost of maintenance is still over 10 grand. And that's with extremely low utilization. You may say, well, why we only run 8 at a time, 8 or 9 trucks at a time, Brian? Why do we even have that many? No matter the age, there's always something going on when you drive this many miles. The sophistication and complexity of the electrical systems in an ambulance, and the fact that they run 24 hours without being turned off, even brand new ones have something. So there's always 4 or 5 trucks, that are in some type of maintenance situation. We don't like it in the wintertime, but they're deers. Things happen, right? So you have to have that backup fleet, and the cost of operating one of these quote older trucks is significant, very, very significant. I'd also point out that the boxes on those 11 old ones are decades old. They've already been remounted a couple of times. So we have literally a paramedic that fell through the floor, and that's the indication of just the subfloor being as aged as it is. So the reason that we got in that predicament, and this is going all the way back to 2007, this is number of units. This blue bar is 911 transport vehicles. The orange is QRVs, quick response vehicles. So that's supervision and those type of things that would be operating. This has been our replacement. We were buying some years nothing, some years 1, some years 2. And when you have a fleet of really 9 or 10 trucks that need to be operational at one time, and you're driving 50,000 miles a year, you never fully replace the fleet. It just, the math doesn't work. And so you can see in 2024, we were able to make a significant improvement. In 25 and 26, all we bought was QRVs. And what we're proposing moving into this year's coming budget is, again, another significant fleet investment. We also think that the newer the fleet, you have some avoidable costs. So this should say 25, 26. But so far this year, already spent $194,000 keeping these pieces of equipment on the road. And we think about 60% of that could be avoided if it was something that was either quote under warranty or not such an aged vehicle. So this is an interesting optic that just demonstrates this blue bar is the age of the average vehicle. The orange line is the mileage of the average vehicle. So you can see pretty aged average here with high mileage. In 2024, we did the fleet investment and lowered both of those significantly. Since that point, we've seen this steady incline, and we can forecast right now there's about between 18 and 24 month lead time if you order an ambulance today before it shows up for you to actually put it in the service. So we can, based on average mileage, average condition, we can forecast what our fleet would look like if there's not an investment made today by 2028. Again, anticipating that 18 to 24 month timeline. And that's what this bar does. If we don't make significant investment, we're going to have the average age being about 4 years with about 150,000 miles. The proposal, you'll see in a minute, is for 8 units, and that will lower our average age to a tick under 2. It will significantly lower mileage, and that'll be at least the proposed consideration for this board is to replace our 8 oldest units. The average mileage on those units are at 220,000 miles. Maintenance cost is significantly higher. All of them have boxes that have been remounted more than once, and trying to keep them in use on a new chassis, for example, would not be compliant with standards. A new unit cost is somewhere around $320,000, and optimistically, lead time is like 16 months, but I think that's going to probably be a bit higher than that. If we did that, what we would have, the old and the new would kind of flop, and with the new would be 8 that we were talking about purchasing. The 10 would be the old. We'd still maintain a fleet of 8, but those old ones would be significantly newer. And I think the interesting part of this proposition, and the reason I'm talking about it inside the capital improvement plan, in a moment, we're going to talk about the DHHS building. And I think that's going to be somewhere around the $10 or $12 million borrowing, as we talked about last year, to completely renovate that space and provide really strong, modern, flexible working environment that'll serve this county for a long time. The good news is the collateral value of that building so far exceeds what we're asking to borrow. It gives us an opportunity to leverage, I think, one time, kind of a catch up to fold this in and amortize this cost of about $2.5 million into the building renovation, right? So let's say that just to give you a very practical example, let's say the total cost of the renovation is $15 million. We have a $3.1 million grant, so that pulls it down to 12, and then you fold in an additional $2.5 million for ambulances. So you get eight new trucks, the building's paid for, your debt service is in between 14 and $15 million, which is what we've funded the debt service fund from an amortization perspective, which is also kind of in your plan to see those numbers to a full. And it's a one-time opportunity, I think, uniquely because of the timing of both, to line that up and to fold that in. Right? Any questions on that before I move forward to other stuff?
How are we able to fold in eight vehicles into a building renovation?
So the bank
It's financed.
Yeah, so the bank is going to collateralize. So when we go to we'll have permitted drawings and all of those things for the renovation, roughly 60,000 square feet. And the cost of that construction will go out to bid and we'll get those bids back. And essentially we're going to market, whether it's a public bond market or to a bank market, to say, we want to borrow, we have a $50 million asset to build that building brand new. It will go through an appraisal, but may appraise for $50 million. And we're only asking to borrow 25% of that. So there's plenty.
No, I totally understand
yeah.
the equity position.
Yeah.
I just thought, banks are pretty particular about, what they're financing, and
Sure.
maybe it's different because of the situation. I'm assuming they'll know that we've got 8
Yeah.
vehicles folded in.
Yes,
to support that.
100%. Yeah. And the local government commission would have to sign off on all of that and all of that. But yeah, I mean, I didn't mean to oversimplify it, but
Yeah.
certainly the bank's going to say, if you don't pay me back for the trucks, I'm just going to take your building.
Yeah.
Right. I mean, it's same idea.
Have you given concern to 18 months is a pretty long time? Maybe breaking that up and maybe consider not having so many vehicles going down the road needing replacement at the same time. Maybe doing a lease for 3 this coming year possibly, and not waiting so long and continuing to spend a lot of dollars on repair.
So we talked through a lot of options. I don't know that we typically talk about an option where you lease 3 years, 3 this year, but the idea is none of our current well, our newest trucks from 2023 can't be remounted, if you will, because they're independent. Our former EMS administrative team felt strongly about 550 chassis, oversized boxes, and this proposal would get us back to a more standard truck. So they're per unit significantly cheaper than what we bought in 2023, and more standard in size and all, going back to a 450 and all that kind of stuff. So our thought is this gets us to essentially 15 trucks that between 2023 and 2028. And then you probably can transition back to a leasing 2 or 3 or 4 and having that in a staggered way. I agree with you 100%. We don't need 7 coming offline at one time and followed by 4 years of nothing. That is not the idea. But we can't really reuse the 550s, and everything older than that is insufficient at this point, both the box and the drivetrain. So before we can get into a staggered replacement schedule, we've got to get to a point where we're at least foundationally solid. And I think we feel pretty good about operating for 18 months with what we have based on the 7 new ones. They're at average 70,000 miles. That's somewhere. So, yeah, about 70,000 miles. If they're going to be in that 120, 130 range by the time the new ones show up. And then largely the majority of those will become the spares that are only being operated when the newest ones have an air conditioning problem or the generator went bad or whatever. We can pro forma and forecast any model at all, but the 2023 order being so different than the rest of the fleet, and then the remainder of the other ones are just so worn out that they offer little to no value.
Also, the purchase of however many the decision is, they won't arrive as one big lump, the same way these last 5 trucks seem to come in, and then they all went into service. It will be spread out over a little bit of a period of time, because manufacturers right now are so backed up with people that already have ambulance orders. We would be squeezing those into the line at 2 at a time, and then they would be rolling out at a little bit more of a staggered rate. So while we have the opportunity to replace however many the board chooses to replace, we wouldn't take possession of all that number on February the 2nd of whatever year. It would be staggered throughout that year, and the mileage would then obviously take over as they put into service. We traveled about 750,000 miles last year, transporting patients and then return trips.
And we should be, your math spot on, we should be at a 3 unit per year replacement. Yeah, that's what we should be. Other questions on that?
So do we move our higher mileage vehicles around now into places related to call volume and?
We try very hard to keep those staggered around so that the busier bases have the newer trucks, which are a little bit more reliable. Station 5 tends to have an older truck up there because of the road salt and the stuff that we have up there, and it doesn't get the mileage used up at Jonas Ridge the same way as it does in downtown Northern.
A big part of the improvement in our call volume is that for the last year and a half, we've not shut down trucks because of mechanical problems, like 2 years. Prior to that, it was less often than often that we had the full fleet of trucks running because of faulty equipment.
What about the smaller versions that we were?
Transit vans, yeah, we still operate. We have 2 transit vans. One's brand new. We use those for interfacility transfers. So full-blown, the James can speak to it better than me, but the diversity of calls on a 911 call, you've got to have full-blown transport unit. If you're doing an interfacility transport, largely the patient's under physician care, stabilized, you know what you need.
I got you.
And it's certainly a transit unit, 125,000, something like that. So a significantly less expensive unit.
So we good there too? I mean, we good as far as that goes?
We replaced one last year, and we have one that we rotate in and out as preventive maintenance is being done. So we are in a good spot there. The minimum requirements for a 911 truck that you have to carry for ALS treat and transport responding to calls. If we were to stick all of that into a transit van, we wouldn't be able to put a provider in there and treat the patient either. They become very tight. So that's the reason why box ambulances are just because of the minimum requirements and the expectations from the office of the EMS.
Now, does that work with our growth expectation too in the future? I mean, building more houses and all that kind of stuff and those kind of things, dynamics?
Yeah, I think it does.
Okay.
I think it.
I can still remember when I was a little kid, the hearse doubled every day.
There we go, baby. It's a lot comfortable for you, ain't it?
Yeah. So, Matt, move on.
Yes.
Just other highlights in your plan. We have two major projects at our Foothills Higher Education Center. One, as I mentioned earlier, is a roofing project, still several years out. We have currently a pretty significant HVAC project. We've already done a significant phase. We've got 3 more rooftop units and 31 indoor units. For those who don't know, that building was a manufacturing facility without a second floor, and then we added that. And so a lot of the HVAC ducting and controls are very customized just to that building, and that makes the engineering for replacement and maintenance very challenging. But we got a significant HVAC project going on now, an RFP that's being drafted, and then that'll leave just a few that we only replace them as they fail. But when they fail, we have to make those better. We've got about $495,000 for computer and PC replacement, public safety radio plans. We talked about that, moving to the 8,000 and the 8,500. That has been a Herculean significant lift over the last couple of years. We've spent about $1.3 million, 400,000 of that with the technology credit from the CAD system that Chris talked about this morning with Motorola. And then we're continuing with our annual allocation, similar to what Chairman Griffin just said, where we're doing a set number per year now that we're kind of stabilized, so that we don't fall behind, and that investment plan will continue. Other EMS capital, we also are neither of these are plans for the upcoming year. They're the year after, but we've been setting aside funding for this for a couple of years. Cardiac monitors and audio pulse machines, both end of life, both very, very expensive, both required to be part of ALS service. And we think that mixing the fleet with old technology and new technology is confusing to providers and is a risk for patient care. So this is just be year 3 funding for those to be fully funded in 2028. These are our IT infrastructure components that are included in that 5-year outlook that you can kind of see here. Here's the IT side, Foothills. We talked about the backup PSAP this morning as part of moving to this location, this campus. These are election machines, CS300s, that we would like to have in place before January of 2028. We need about 48 of those. So again, our department heads do an incredibly good job of looking ahead, forecasting, and allowing us to incrementally plan so that we do not have to have a significant year impact. Our water sewer fund, again, Indian Hills is unfunded, but it's listed as a top priority. In the solid waste fund, we know that we're working towards MSW. We have we switched environmental engineering firms this year, as you all know, and part of their master services agreement and an engagement is they're doing MSW exploratory engineering right now to tell us what is the path to handling our own MSW solid waste. In the meantime, even if we started today, it's a 3 to 4 year project. So we're going to have to continue to operate our transfer station, which needs a floor resurfacing. That'll be part of the capital program. Nothing significant, just something keeps it operational while we continue to try to do this planning. And we've applied for a DEQ grant that would add a collection site at Marsh Trail. People on that side of the county really don't have a very convenient recycling center, but it would also relocate our current scale and build a scale house. A $5 million grant, no match, and that really helps modernize and increase efficiency at our solid waste facility. And tub grinder. Mark said, the tub grinder.
Gotta have it.
Yeah, that's important. Grinding brush is very expensive. So quickly on major projects, you guys are well aware, the board, commissioned a facility master plan back in 2020 with Mosley Architects, and you rated each of our buildings in one of 5 systems. And we've tried to make a significant impact over the last couple of years, in dividing those through the capital improvement plan into short, midterm, and long-term, projects, both funded and unfunded. We've talked a lot about, many of the projects that have been completed. The next on the list is the Health and Human Services Building. So that, Greg Melton is here somewhere. There he is. He and Corey and Danny and Ashley and really the whole team have worked really, really hard on what I think is a strong program. I'd remind you, this is it's certainly about 250 full-time employees. And I'll let Greg come up and walk you through the floor plan, but he has given us a low and a high estimation of cost, based on the current drawings, which are pretty significantly, far along. There's some alternates there that could have, they are built into those, so it could be something where that's removed. A rough timeline, for the project, looking at a Q2 2028 potential completion. And I'm gonna let him walk you through the floor plan and the design thoughts and all of those things. And then between the two of us, we'll try to answer questions.
Not a computer chip.
Well, we've got one up version in the next slide, so I hope you'll be able to see a little bit better, but yeah, appreciate the opportunity to come and talk to you this afternoon. And, I want to comment on, I guess, through the project, too, that's wrapping up. EMS, I hope everybody enjoyed the ribbon cutting the other day. That project, did a re-inspection on it this morning for, cosmetic, items that were on the punch list that are being addressed. And, so we should, see that one fully closed out here pretty soon with a couple of documents going to the city of Morganton. So it's gone very well. Animal Services, I know everybody's looking forward to that ribbon cutting coming up. If you haven't been to that facility in a while, I know Kate could probably speak to an impressive facility as well. That it should be exciting for all you guys to see. But as far as the HRC project goes, as Brian mentioned, we've already spent a lot of time with several folks in the room. Danny may have stepped out, but we've got Ashley Jarrett over here. There's Danny. Danny and Ashley have been integral to the public health side of things, as well as Bobby Smith, who attends a lot of the meetings, and Amy's done a great job facilitating, getting all of us together for input. And then we got Corey over here. I didn't see Amanda's not here. Corey and Amanda Grady, as well as Chaslin and Kelsey have, we've had great input to the meetings. I guess one of the things that took a while to materialize on the front end of this project is taking a step back from the CHIN study, which was done several years ago, and then reassessing post-COVID, what a lot of these departments look like as far as who's in person, who's remote, where we potentially see growth, and then essentially coming up with a new program at that point. So at a real high level, the building will, the project will constitute or be made up of 57,000 square feet of renovation. Just at a real high level, the lighter green in the top left corner represents DSS Financial Services. The blue beside it is public health. The darker green at the bottom right represents DSS Child Welfare. And then the tan spaces are what we'll call common or multi-purpose spaces. So this next slide shows the front of the building as if you were to approach it from Parker Drive. There's a shared waiting space that is utilized by both DSS Financial Services as well as Public Health. So wayfinding should be very easy as you come into the building. There are two stations of the 5 stations that serve the financial services side, and the remaining 3 serve public health. James, please.
Yeah.
On the DSS Financial Services side, we work to create areas that will serve the 9 teams that are in that area. So there are 9 teams that work within this space here. All of what we'll call the public-facing teams are closer to the front there. So these folks up here are folks that regularly have meetings with the public, as well as maybe do intake work. So the public will stay in this third of the space over here, while most of the non-public facing, spaces are here to the rear. And, what we tried to do with the building as a whole, because there's just so many offices and workstations, is to make sure we didn't have these long, dark corridors with offices or these masses of workstations that make it look like a, cubicle farm, for lack of a better term. On the public health side of things, as I mentioned, you have check-in, up here, or intake. Then the folks will be immediately moved to the subwaiting area, which is adjacent to a larger lab that has 2 lab toilets and a blood draw area here. The WIC lab, is right here. So these folks will be in proximity to all the lab, blood draw, and, lab toilet spaces, right from the subwaiting area. The clinical core of the building, or the public health side, is what we'll call a Disney concept, which allows, staff members to service all of the clinical spaces from the rear of the spaces without having to be in the public corridor. So essentially what I'm saying by that is you have the, clinical exam rooms here. All the staff members who serve those exam rooms are back here, so they can pop in and out of these exam spaces without being in these public corridors to give them, more efficiency. The WIC area, as I mentioned, is here. It also has the Disney concept where all their offices and workstations, are behind the, consultation rooms and lactation rooms, so they can also enter from the rear and not be in the public corridor. These spaces are also positioned where either the exam spaces or the WIC consultation rooms can be used by either public health or WIC, which is, sharing the spaces instead of creating duplicates. In the bottom right corner of the public health space is your administrative, suite, which has the administrative offices as well as health preparedness and public health offices and storage and support workstations down here. It's taking advantage of an existing entrance that's, to the right of the building, which is really the entrance that you guys use now. It is worth noting that all the building entrances are staying where they are currently, which we do think will help with wayfinding, for the public, moving forward. We are planning to, have windows installed in many of the perimeter offices, which is one thing that the building right now we think lacks is this public light. Or is, natural light.
Mm-hmm.
And the DSS and DSS child welfare area, you can picture the spaces as they are right now. Essentially, child welfare operates at an area that is a little bit bigger than the tan area that you're looking for right now. And I know Corey will agree with me on that, right? So the space that is green here, is primarily occupied by the school system right now. And so you can see, what they were working with, and if anybody that's been in that space recently can see the congestion and the amount of work that's being done and the bodies that are in such a small space. So the green space is what they will be working with, moving forward. So they will have, their own entrance to the side, which is currently the school's entrance, now. You do have your public facing spaces near that entrance, which, there are visitation rooms with an observation room, between them as you, look to, supervise some of these visits. You also have conference spaces, near the front vestibule as well, that allows for some of these face-to-face meetings that public meetings that you don't want those folks to get back in the entrance of the office space, as well as, restroom, shower facility, laundry facility for when they're doing intake for some of these children that are coming in and may need to be bathed or, clothed, et cetera. There's also a large storage room, for the number of site visits that happen in the, car seats that are taken in and out of the facility on a daily basis. The administrative portion of, DSS is down here. It also the, I guess their legal department there, because I know there are a lot of hand-in-hand conversations that happen between the administrative function of DSS and the legal department. And then the remainder of the DSS, child welfare support spaces are, in this area, which will give them flexibility as some of those departments may grow or shrink. Their clerical department, which needs a little bit, more seclusion, is, up near the front of the building, in its own little suite there.
Where's the elevator? I keep looking at these drawings and I can't figure
Right here is the elevator.
Okay.
Okay. Yeah, so the building changes height along this wall right here, if that's helpful. Those who've been in it, this area down here is actually 4 feet lower than the upper area. The tan space back here, has a large multi-purpose room that seats about 80 at tables and about 130 in chairs. One of the common requests as we met with departments was, we have a lot of meetings just for the sheer size and the number of folks that we have in the building that we can't accommodate with any space in the building or a combination of spaces. So that space, will be sufficient for those size meetings, as well as it can be used after hours. It's designed to be used after hours, and it has its own restrooms. We do have some shower facilities in the event that I believe emergency preparedness had requested those, and just to give flexibility if there's some staff that may have to be at this facility overnight or needs to shower. IT and HR has a suite down here as well that has a conference room in case there are any sensitive meetings that need to happen kind of out of the main flow of the building. But that is really what we have on the main floor at a really high level. On the second floor, the usable area, we are proposing to have workstations and offices that could be, I guess, utilized by a number of the different departments, depending on whether some, especially with DSS, a lot of these departments have a pretty significant head count of folks that work from home. However, when those people may either find a new position or be replaced, the new hire has to be in the office for some time period. So we do need a space in the building that can accommodate, if we have ebbs and flows of the people who are remote versus on site. It is important to note too that especially within the DSS area, Corey and Amanda have identified any departments that have been growing, and we have at least 15% extra capacity built in with this concept as of what is there now.
So does this space accommodate everybody that, if everybody came back to the building, this plan accommodate that?
Like adult protective services would do.
They will not be housed here. They'll stay on Avery.
The goal was to not add square footage, to stay within budget.
Is that a problem? Before, I don't know, I'm asking.
We developed, ahead of this meeting last year, build a whole new building, a renovate space, live in addition, or just renovate. And the direction that we got was just renovate, largely based on cost. I don't have last year's data in front of me, and I'm sure we've changed, but building new was something like 45 million. Renovation with addition was something like 25, and just renovation was something like 10 to 12.
And a lot of those were based off a Chin study, which I believe happened at a time where hiring probably was outside of the norms, for staffing. And so that was part of what we revisited for the first several months of the project, is what is the reality of what is needed with the folks who are likely to be on site.
So we think this has gone up about 20% since last year, cost to renovate.
Well, there's a $1.7 million alternate that is the large meeting space, the 5,000 square feet that's go back. So, at that time, that cost estimate, we had not retained an architect. So it was professional staff saying, how much square footage are we gonna have to touch? And I'll end up, I'm sorry. The 10 to 12 estimate was based on two things. one, we didn't think the school space needed a lot. And two, we took basically square footage we thought we would touch and multiply it by a factor of $200 a square foot, 225. And ultimately we ended up needing to touch more than that, including the schools. There has been a little bit of cost escalation, but not 20%. I mean, marginal cost escalation. But I think the bigger deal is touching more square footage, including the schools, and just not having the exact drawing. But this space, it's about 5,000, is about right? That's about 1.7 that I also didn't consider in that.
Does this plan allow us a future space for expansion if we want to add space, as we kind of?
Yeah, the best option for that, absolutely, yes, would be toward the front of the building where we're on, what was originally cut as far as the site grading, to either side. We want to stay as much away from the rear of the building as we can for the sake of the amount of fill that happened there when the original building was constructed.
So it's the front door at the top of the screen?
Yes, sir. Yeah, this is short park room.
So is that thing to the right, is that cover on it?
Yes, sir, and we're proposing that it stays.
So potential expansion would be to the right.
Which would go hand in hand with some site, you have to rework the parking areas. In fact, there probably will be a little bit of that with this because right now there's the only through lane on this side of the parking is through the covered drive, and my understanding that there's some pedestrian safety issues there, so there'll be a little bit of that with this phase. But yes, the best areas to expand would be directly to the side.
So are we satisfied with the adult protective services operation now? And
I mean, Corey can certainly, we've talked about it a lot of times, but they work very independently. They seem to be settled there. I think walk-in intake has upticked a little bit since they've been there. So I don't want to speak for the whole department, but I think that's the case.
For sure. I mean, I think the location for adult services makes sense. I think it works. So I think from DSS's perspective, like, especially in child welfare, like our intent is for those workstations not to be necessarily individually assigned to an individual person because social workers come and go. So in a sense, it does allow for future growth because they're not necessarily, it's not someone's workstation. It's just, we try to create enough workstations that we sort of figure what's the most amount of people that could be here at any given time. Do we have enough space for them? So I do think from that perspective, we did take into account, could there be more in the future? Like in a perfect world, having everyone under one roof would be fantastic. But I think Brian's point, I think adult services works well where it is. The space is really nice. I think obviously they're comfortable there.
And I will say this from an architectural standpoint, I was a little worried when we started the project that we would maybe have segmented spaces that were on what I call the lower level of the main floor and then the upper. It actually worked out really well with the size of the spaces that we have there, that DSS child welfare is down here, all on the lower level, financial services and public health, all on the upper level. So we don't have any that are split between the two.
So Corey, somewhere around 2014, 15, the state passed what they call the Marcy's Law. In order for us to be compliant with that, we were looking at the addition of 24 staff members. Are we prepared for something like that?
Ryland's Law, I mean, there are caseload standards that DHHS has. I don't think that they're not enforceable caseload standards, so. I mean, I think that this does allow us space to appropriately meet the needs. I mean, it's particularly in child welfare. I do think you had substantial growth in economic services where those people don't work in the community, they work in an office, so the people that are there, like those are their spaces. So if you had significant growth there, like that would be a little bit more challenging, but I think we try to create it, again, working with the parameters we had, I think we tried to create as much flexibility and opportunities for growth as we could.
Like I said, we evaluated the 9 teams, and every team that has shown any growth has at least 15% extra growth in this plan.
And nothing here would prevent future expansion. It should be, and I'll tell, I mean, just from a staffing perspective, and we've looked at every single department. There is some workflow efficiency improvements that are already being worked on. But I don't think it's realistic to think that the Department of Social Services or Public Health are gonna see significant staffing upticks based on comparisons, benchmarking and those type of things. Down the road, if it did happen, there could be expansion on site, but this, I feel pretty confident saying this is about as efficient as this building can work, given where the exterior walls are now.
And I don't think there's anything that we're doing that's gonna, that we're gonna say, I wish we wouldn't have done that if we add on to this building. Most of these, if, you know.
Compare that to the courthouse, like, you know, at one time there was talk about expansion of, to get another courtroom and to get some of that stuff. Like the efficiency improvements of moving the district attorney and adding the courtroom. Like if we ever, 25 years from now, there's significant population growth, changes in judicial process, and we need to add on to that building. We thought about that as we were programming and designing it today, and like there's a path to do that without undoing anything that was invested. Is that fair?
Yeah, I think it's very similar comparison. Honestly, in fact, in other conversations, you know, this building footprint, other than the fact that it's on two levels, is very forgiving and also not very different than what we would do if it were a new building. Now, obviously, you know, cosmetically from the outside, that there'll be some things that, you know, we may want to approach and improve. I think that we need to, we are proposing new storefront at many of the entrances. So there's some things that we're going to need to tackle from an exterior perspective as well. But the column grid is, you know, what I would call a modern column grid. The mechanical systems, even though there are some problems right now, you know, we feel confident that we can get them to serve this space very well and in a modern way. So I don't know that I can point to any specific thing and say, I wish that weren't there, because it's really, you know, pushing us in a position we don't want to be in. And so I think it could be a home run for what you'll spend versus what you'll get from this project. Hey, Corey, I don't know, you know, I know I want to speak a little bit about the time that you and Amanda have spent and your staff has spent looking at this plan, and maybe you could talk a little bit about your comfort level with where we are versus, I mean, I would tell you that, you guys have probably invested as much time as anybody I have seen on the front end of a project, analyzing a plan.
For sure. I mean, I think we've optimized the space. I mean, I think, I actually feel like, you know, going in, but maybe a little more concerned. And I think going through the process, feel pretty good about, like, I mean, they've been very open to, I know Amanda has a lot of ideas and thoughts, a lot of revisions based on Amanda's thoughts. But I mean, I feel really good about, given what we had to work with, and this is, you know, a really good option moving forward.
And I guess on the public health side of things, I don't know if there's anything you guys would like to add, or.
I think we've squeezed as much out of it as we can. There's no room for growth there. The health department grows any, it's going to be a problem. The public health is actually involved with this footprint of this plan because it ceded some to social services. So in terms of the actual square footage we have, we're probably a little smaller. We've done as much as we can to have people working from home or working in temporary spaces. I think the biggest challenge you're going to find is operating these clinic spaces while you're doing that renovation. It's going to be exceptionally challenging, and if you break that service, there are people that won't get that service. And at the same time, you have a bunch of employees who really can't do much else. We can't take a lab director and put her in some other position, or a nurse and put her in some other position. They either can do the stuff or not. I think that's going to be an exceptional challenge, and it could be costly if you have to go off-site somewhere to operate the clinic space.
And one of our upcoming meetings, just to shed light on that, on the 19th, we're meeting to talk about, you know, what will stay in operation, what are the needs for those spaces, and then make sure from a wayfinding perspective for the public that they, you know, it's going to be something that folks will be able to make it to the site, understand where they need to go for those services in the interim time period too. I think, you know, everybody is prepared to have those conversations, and is going to bring information on what those needs will be. And I guess that back to yes, the public health area is roughly the size that it was. It is reconfigured in a very different way that we hope to see some efficiencies. And to expand the public health area will be to extend this clinical corridor this way with an addition. Again, so we've not built the public, we've not built these spaces in the middle of the building, and to get to an addition is going to say, all right, now the 20,000 square feet we just renovated, forget about that. We're going to have to blow it out. It's going to become something completely different. Both of these spaces will see opportunities for additions.
Other questions? There you go.
I'll just close with, I think, are well aware that operating, an adaptive reuse project in a building that's continuing to be operational is a heck of a challenge. We just did it for 2 years almost in the courthouse. It's not easy. It takes flexibility and understanding and phase logistics and planning, temporary relocations and all of those things. So that's going to add one layer of complexity to it. It's also going to impact the cost, right? When you're telling a contractor start and stop, not everything's going to be perfect. You order materials, they're a week behind. We told this group this, but all of that's going to happen. But you're getting essentially a new space for 80% cheaper than it would have costed to build a new, and it'll serve this population, this community for a long time. So, we'll hear more about that. We're not taking action on it today, but I did want, it's really the final remaining funded large major capital project that we have. And, I just wanted to make sure we were staying caught up. I would remind you that our debt service fund, not only do we have exceptionally low debt, 82% 10-year payout, 1% debt service assessed value, and all of those ratios that are inside your policy that are incredibly strong. But we've also started funding this project 2 years ago incrementally in our debt service fund, overfunding it. So when the amortization schedule does start, they'll, just like our out-year capital, we've done out-year debt service funding too. So there will be no significant one-time massive impact on the budget. We're inching our way